Good morning. Thanks for joining me. My name is Dr. Kevin Dawravoo. I'm a hematologist oncologist here at the Warrenville Cancer Center. Today we're going to be talking about upper GI cancers, and I want to keep this talk very open. If you have questions or comments, please just type them in and I'll try to get to them throughout the talk. So, just talking very generally, cancer is a disease caused by uncontrolled division of abnormal cells in any part of the body. So cancers occur when there's a change in the DNA, and this change then allows that cell to proliferate and grow at an uncontrolled rate. These changes in the DNA are also called mutations. Now, there's a lot of thoughts that we all, whether healthy or not, we have these mutations occurring in our body at any point in time. And the thought is that our body's immune system is able to identify these changes and, for the most part, kill them before they turn into a cancer. However, there are instances where the immune system cannot detect these mutations due to the way the cancer is growing and the camouflage that it's able to exhibit. And that's when we develop cancers. So today's talk is going to be talking about just the upper GI system, and what that means is, so the gastrointestinal tract is about 25 feet long, and that encompasses everything from the mouth to the anus. Now, the upper GI system includes the esophagus, stomach, liver, bile ducts, and the pancreas. And so those are the primary areas that we're going to be talking about today. So the esophagus, it's a long tube that essentially connects the throat to the stomach. And there are approximately 18,000 new cases of esophageal cancer that occurs in the United States each year. It's more common in men than women. It's the 6th most common cause of cancer death worldwide. And some symptoms of esophageal cancer, they can be subtle. Most people start talking about how food begins to get stuck when they swallow, or they have more difficulty swallowing. Another word for that is called dysphagia. This can progress as the tumor gets bigger to odynophagia, which is pain with swallowing. As patients get more difficulty swallowing and pain with swallowing, then they start eating less, and so that can lead to fatigue and weight loss. So really, these are the most common symptoms that we see at presentation for esophageal and even gastric cancers. Now, you may ask, what are some risk factors for developing this cancer? Well, lifestyle issues come into play with esophageal cancer. So tobacco use, alcohol, obesity, and chronic reflux. These are all some of the major risk factors for developing this type of cancer. When discussing esophageal cancer, we have to be aware that there are 2 major types. The first is adenocarcinomas of the esophagus, and then the second is squamous cell carcinoma. Now, adenocarcinoma is basically a cancer of the glandular cells, while squamous cell carcinomas are cancers that develop within squamous cells. Again, both types can be caused by cigarette smoking, but when speaking specifically about adenocarcinoma, this cancer has been seen to develop due to long-term reflux. And so what happens when you have chronic heartburn is that the acid can actually cause damage or changes to the lining of the esophagus, and those changes can turn into what we call Barrett's esophagus, which then can lead to cancers if not properly surveyed. And so other risk factors for adenocarcinomas include obesity. And then when speaking about squamous cell carcinoma, this is a cancer that you have to think about anything that can cause caustic injury to the esophagus. So, like we said before, smoking, alcohol are very high risk for this cancer. Also, drinking extremely hot liquids can, over many years, can cause this type of cancer. Other things that have been noted include unhealthy diet and even poor hygiene have been correlated with this type of cancer. So there's been a dramatic shift over the last 60 years in terms of the frequency of squamous and esophageal squamous cell carcinomas and adenocarcinomas of the esophagus. In the 1960s, squamous cell carcinomas of the esophagus actually made up over 90% of esophageal tumors in the United States. And adenocarcinomas were considered so rare that there were even some physicians who felt that they questioned their existence. However, over time, as our population has changed and obesity rates have risen, that can possibly lead to higher rates of reflux. Adenocarcinomas have become now the predominant type of esophageal cancer, making up over 60% of all esophageal tumors compared to squamous cell carcinomas. So when speaking about staging, first off, with any type of cancer, the first step is to make the diagnosis. And the way we do that is with a biopsy. Now, with esophageal and gastric cancer, the most common way that we make the diagnosis is through EGD, or endoscopy, where a gastroenterologist will take a tube with a camera on it and go through the throat, down the esophagus, and into the stomach. By doing that, they're able to visualize the tumor and then also at the same time take a biopsy. And so once we have the biopsy, we have the diagnosis. The next step is to stage it, and this is a very critical part of the disease workup. And the reason for that is we want to make sure we get the appropriate stage, because treatments can differ and prognosis differ based on the patient's stage at diagnosis. And so when speaking specifically about esophageal and gastric cancer, we talked about doing EGD. The next step is to do a CT scan. And what that is basically a scan of the body from the neck to the pelvis, trying to determine, has there been any evidence that the cancer has spread to other organs or surrounding lymph nodes. If the CT looks good and it doesn't look like there's any spread of cancer, then we go on to a PET scan and an endoscopic ultrasound, also known as an EUS. These two tests will finally give us our complete staging, and then based on that, we are able to develop a treatment plan. Our model here at Northwestern has been to utilize a multidisciplinary tumor board. So we have a team of doctors that specialize in GI cancers, myself included. We have 2 GI surgical oncologists. We have our GI radiation doctors, our pathologists, our radiologists, and multiple other physicians at this meeting. And so basically what we do is we bring all the information, we talk about each case, we go through their biopsies, we go through their imaging, and then we sit down and try to talk about the best way to treat that patient through a multidisciplinary approach. And, again, speaking in terms of staging for esophageal and gastric cancer, these cancers tend to be very aggressive. And part of the problem, not just with this cancer, but with other upper GI cancers like pancreatic and biliary cancers, is that patients often present late in their disease process. So 50 to 80% of patients, depending on which literature you look at, actually present with incurable disease before they even get to the oncologist. And that's really what makes it so difficult and why so many patients die from this disease, is that we're just not able to catch it early enough. So I typically will break down an esophageal and gastric cancer patient into 3 categories. First is early stage, then intermediate, and the final is advanced, unresectable, or metastatic. For early stage patients, these patients have a very high chance of cure. And the way we can do that is through endoscopic resection or surgery. Now, endoscopic resection is the least invasive of all the treatments. Basically, we have a gastroenterologist go in, again, with an endoscopy. They go in through the mouth and they try to cut out the tumor. Making sure that we have the pathologist look at the tissue that comes out and make sure that there's no tumor left behind. Now, these are reserved for the earliest of stages. If the patient has a little bit more advanced disease, but still early stage, then they will have surgery where they have part of their esophagus and or stomach taken out. Most patients will fall into intermediate or advanced disease, however. And so for the intermediate patients, these individuals get treated with chemotherapy and radiation together. They get put on a chemotherapy, they get IV once a week, and then they get radiation Monday through Friday for about 5.5 weeks. And then about a month later, they'll go for surgery. Now, there has been a dramatic shift over the last year in terms of what we do for esophageal patients after surgery. In the past, we would give them chemotherapy, radiation, followed by surgery, and then put them on surveillance. And what surveillance means is they just come in, see their oncologist, we do an exam, we get blood work, and then we do CT scans to make sure that the cancer hasn't come back. What we found was that despite all our efforts, and even if patients undergo everything very smoothly, there's still a very high risk of recurrent disease. And so a study came out last year showing that patients that underwent chemotherapy and radiation and then got surgery, and after all this was completed, they followed up with immunotherapy, they did much better. So much higher cure rates. And so now this has become the standard of care for patients who have residual disease after surgery. And I'll talk a little bit more about immunotherapy later on, but this has really changed the way we treat esophageal cancer. And again, I would say this change has happened over the last year and now is the standard of care. For patients with advanced unresectable or metastatic disease, most of these individuals are incurable, but they are treatable. And what that means is, we can treat them with chemotherapy or immunotherapy, and the goal of that treatment is really to try to control their disease for as long as possible and prolong their life. So moving on to a different type of cancer, I wanted to talk about cholangiocarcinomas, which is basically a cancer of the bile duct. Now the bile ducts are in the liver, and they help drain the bile from the liver. Okay, and so when you develop, these are pretty rare cancers in the United States and all over the world. But again, they're very aggressive and highly lethal. And part of that reason, again, is that the fact that most patients present late in their disease process. So they have advanced or incurable disease by the time they get to see the oncologist. Some signs and symptoms of patients with bile duct cancers include jaundice. So if the bile ducts get blocked, then the liver can't drain properly and the bile builds up and a patient can get yellowing of their skin and eyes, which is also called jaundice. They can get clay-colored stools, they can get itchiness all over their skin, and dark urine. Other symptoms include abdominal pain. Weight loss is very common in at least half of the patients that come in with this disease, and then fevers. Liver cancer is another upper GI cancer, and we see that very commonly in patients with cirrhosis. The liver cancer has also changed dramatically in the last, I would say, 12 to 24 months. We now utilize immunotherapy for liver cancers because we found that immunotherapy is effective and can be more effective than certain chemotherapies. So that's been a dramatic shift for patients with hepatocellular carcinoma. We also use a number of new oral agents. So these are therapies that target specific pathways within the cancer process. And for the most part, many of them are just pills. So the patient gets to take pills at home, and that's the way we treat their cancer. So liver cancer is another one that has had a number of changes over the last year or two. Now going on to pancreatic cancer, this is one that everybody's heard of. It's the fourth most common cause of cancer-related death among men and women. And again, with pancreatic cancer, what I typically tell patients is that out of all the patients that come to see me, 40% of patients will have stage 4 or incurable disease by the time they get to me. Another 40, maybe 45% will have disease that has grown to the point where a surgeon cannot easily take it out with surgery. And so, you're looking at 80+% of patients have incurable disease by the time they get to the doctor, and then the remainder have disease that is resectable, meaning a surgeon can go in and take it out with surgery. Some common presenting symptoms include abdominal pain. Pain is typically in the upper abdomen. Patients often describe pain as radiating straight to the back or around the sides. These patients can also present with jaundice, which is that yellowing of the skin, weight loss, and then pancreatic cancer has a high risk of developing blood clots. So unexplained blood clots could also be a presenting sign. Risk factors for pancreatic cancer. Genetics is one that we have learned over the last few years is a major player. Over 10% is probably the number where we see there's a genetic predisposition for this disease. Cigarette smoking, obesity, vitamin D deficiencies has been shown in some studies, and then chronic pancreatitis and diabetes. So there's an association with new onset type 2 diabetes in the development of pancreatic carcinoma. So there are many different treatment modalities we use for pancreatic cancer. I've already talked about surgery. We do utilize chemotherapy, and sometimes we will use radiation therapy. I typically define pancreatic cancer patients into 4 categories. The first category is resectable disease, and so that means that a surgeon can go in and take out the tumor. The second category is borderline resectable, and this has really come into play over the last few years as a distinct entity. So these tumors could possibly be taken out with surgery. However, they are starting to grow near some of the important blood vessels. The next category is locally advanced unresectable, and what that means is these tumors have not spread to other organs, so they're not stage 4. However, they have grown around very important blood vessels, making it difficult or impossible for a surgeon to go in and take it out safely. And then the fourth category is stage 4 metastatic disease. For the last, I would say, 5 to 6 years at least, there's been a shift in how we treat these tumors. In the past, and when a patient had resectable disease, we would always do surgery up front and then do chemo and possibly radiation after. What we've learned from some initial studies is that patients may do better if they get chemotherapy first, even in the resectable setting. And so we even have a trial here looking to answer this question, where we have 2 groups of patients with resectable disease, and one group goes on to chemotherapy and then surgery, and then the second group goes on to surgery and then chemo. And so what that trial is trying to answer is, do we need chemotherapy before and after surgery, or is it better to take patients to surgery up front? Now, talking about the different types of therapy for upper GI cancers, chemotherapy is probably the mainstay. It's the most common treatment that we use. And chemotherapy is basically the use of drugs to destroy cancer cells. It works by preventing cancer cells from growing and dividing into more cells. And it utilizes chemicals to interfere with cell division, and then it also damages the DNA of these cells so they stop replicating. Immunotherapy is the newest thing in oncology, and it's basically a treatment that utilizes an individual's own white blood cells to attack the cancer. And the way it does that is cancer cells are very smart, and so they are able to camouflage themselves from our immune system by binding to white blood cells. What immunotherapy does is they inhibit that binding process so that your immune system, your own white blood cells, can then recognize a cancer cell as foreign and then attack it. Immunotherapy has many benefits in that, generally speaking, it is probably better tolerated than chemo for the most part. And also, with immunotherapy, we've seen some amazing responses in a minority of patients, a fraction of patients, not a lot, but we've seen these responses where patients' cancers would sometimes, be very well controlled for a long period of time. And we've never seen results like that with chemotherapy. So it's definitely exciting. There's a lot of work to do. And by no means is it a home run or an answer for every patient. But in the right patient, immunotherapy could be a good choice for them. Other types of treatments include targeted therapies, where we focus in on the patient's individual cancer. So almost every patient with stage 4 disease that's a candidate for treatment, in my practice, I will get what we call next generation sequencing. And what that means is we basically sequence the genome of their tumor. We're looking to see what mutations are driving their cancer's growth. And we have a trial here, and there are many trials all over the world actually looking at this, where if there's a mutation in that patient's tumor that matches with a drug on our trial, we can utilize that drug to treat their cancer. And so it's very exciting for us and for the patient, because this is more of a personalized medicine approach, meaning, we're not just saying you have esophageal cancer and we're going to give you X chemo. Now we're saying you have this type of cancer with this specific mutation. Let's try to treat it with a drug that actually goes after that mutation. So that was just sort of a brief overview on upper GI cancers and some of the treatments that we utilize. I just wanted to open it up for questions at this point.
So you spoke about pancreatic cancer and the prognosis and when it's detected, it's can be very, like you said, lethal and deadly. Are there any, outside of screening, is there anything, genetic testing or screening, high-risk clinics that patients should be considering if they're concerned about pancreatic cancer? Yeah, so I would say in the last 2 to 3 years now, we have a genetics counselor at every tumor board. And any patient, whether you're 16 or 88, if you have pancreatic cancer, they all get sent to the genetics counselor now, because we do feel that there are diseases like this that run in families. And so we would screen the individual that was diagnosed with a cancer. We wouldn't necessarily screen their family members at this point,
but we would screen the individual to see if they have a genetic predisposition for developing this cancer, and that could have implications for their family members.
I've heard H. pylori can be associated with some stomach cancers. Can you talk a little bit about that correlation?
So H. pylori is a bacteria. It's very common in people. And so over time, H. pylori can increase the risk of certain like gastric cancer. And so many times for patients, if they're having, chronic reflux, their doctor will test for that, or if they get an upper endoscopy, the doctor will look for that. And if they have it, it's a very simple treatment or cocktail of antibiotics that patients would get to eradicate that. And then what we would do is we would follow up on that to make sure that the bacteria is actually cleared by testing the stool for the bacteria. If it's cleared, then you're good. If it's not, then you would go for another round of antibiotics.
It sounds like upper GI cancers, there are some steps that we can do as patients to help prevent, right? I've heard you say, smoking, drinking, obesity.
Yes.
Are spicy foods associated with upper GI cancers?
Not that I'm aware of, unless it's hot. It's more the heat of it causing caustic injury. Okay. That's where we worry about, increasing the risk of an esophageal cancer.
Okay. And then what about diet? Is there anything special diets or, obviously it sounds like a healthy lifestyle, maintaining a healthy weight.
Right.
But any special diets, or you hear about the different types of diets that are out there. Is there any one particular one that you think?
I think the most important thing is just leading a healthy lifestyle. So that means exercising and just, eating in moderation. We do know from colon cancer literature that, red meat, so that's beef, lamb, pork, is a carcinogen. It does increase the risk of colon cancers. So, and I haven't taken a look yet in terms of upper GI cancers like esophageal or gastric, if there's a correlation there. But to me, I would try to decrease consumption of those if, we already know it causes one type of GI cancer.
I don't think we have any other questions. No. So thank you so much for taking time this morning to give us an update on upper GI cancers. Very much appreciated.
It's my pleasure. Thank you.